Thanks very much. It's really wonderful to be here, and it's a real sea change to even have a conference of this prestige start with a consumer, patient, participant. Usually we're last on the last day before the janitor is sweeping up, so I'm really delighted to be able to come and talk to you today about what little can do for big data. I'm going to start with little kids. These are my two little kids in 1994. They were diagnosed with a big disease, pseudoxanthoma elasticum. PXE for short, you never have to say pseudoxanthoma elasticum again after you say that PXE is not a big disease in a lot of ways. It was for us. It's a rare condition affecting only about 1 in 100,000 people. When they were diagnosed 2 days before Christmas 1994, we were shocked, just like any parents would be. The day that you kind of step over that diagnosed line is quite a day, and you can't go back. We very quickly learned that it's a numbers game, but it's not really a data game when it's this small, with just 2 kids. There's no deli number. We expected the day after Christmas to be able to go to someone and say, so, okay, they have PXE, what do we do? What's the treatment? What's the progression? What's going on? No one knew. And we also thought that somebody would give us a place in line, that we'd get to P eventually. But we quickly learned that none of that was going to happen, and that, in fact, we had to take this into our own hands, like many parents had done before us, and certainly many, many have done after us. My husband was an engineer for a fire protection company, and he drew this diagram of where we needed to go within the first month. Neither of us have any science background. I have a master's in religious studies, and he has a drafting degree. You can tell that this looks a lot like a plumbing diagram. And in fact, it's held well. We've worked on every one of these blocks over the years, and they've provided a very good map for us to go from one place to another. But I'm not really here to talk about the science of PXE or the science even of rare diseases, but instead to talk about the culture and the way that we're moving in data that I think can be very important. To herd cats, you simply need to move the food, is the saying. And for us, that was really true. We first thought we would easily motivate the scientists who were interested in the condition to work together, that information seemed to be the parlance that they had and needed, that data, whether it was from biological samples or actual clinical information, was important. And 2 days after Christmas, scientists from Harvard came and took the blood of our 2 little children, ages 5 and 7. And 2 days after that, we got a call from Mount Sinai Hospital, and they said, we're 2 scientists who are coming to take the blood of your 2 children. And we said, oh, we'll just go to those other scientists at Harvard, and you can share. And they said, share? That's ridiculous. And you can imagine, as a family, we thought it was ridiculous that they wouldn't share. We then said, well, work with us. We'll get the blood and tissue from various families. We'll bring it together at the time we're looking for the gene, and you all can work together. They said no over and over to us, and this is where we decided, well, we would move the foods. So we created a blood and tissue bank. We created a registry. We created a way to aggregate this data. And working together with scientists from all around the world, my husband and I were able to borrow time in a lab at night to find the gene ourselves, to patent the gene so that we could become the stewards and really make sure this gene stayed open in the days when that wasn't so clear, and to go on and do all the other things you need to get to a therapy. We're now in a clinical trial at Mount Sinai Hospital for this condition. But again, this is really not the key part of the story. Even though we had 4,000 people, even though there are 10,000 biological samples we were able to garner, 900 fields of data over 20 years, we really felt this was too slow, really much more not as advanced as other fields we were seeing. It wasn't enough. And so we began to work very quickly in the late 1990s with Genetic Alliance, which, as Alice told you, is an advocacy organization working really to empower families, communities, individuals. There are 1,200 disease advocacy organizations under our umbrella, and there are about 10,000 diseases represented by the work that we do. That's really great too, but there's so many silos when we do work this way, when we divide things by the names of diseases, sometimes in very archaic ways, when we don't look beyond those borders. Often we were told, but it's like trying to find needles in haystacks, so we really have to do these things in a way that is these silos, is these structures that would make sense. And we kept pushing back, saying, but the haystack is made of needles. Every single one of us is important to the solutions. It doesn't matter if you have PXE, a mutation in the ABCC6 gene. It doesn't matter if you have cystic fibrosis or diabetes or cancer. These pathways are going to be really important to each other. Rare diseases are actually just exaggerated pathways for common ones. All common ones are rare. All of this is converging finally, and we're really coming to a place where I think we can make a difference. For people with conditions, as you all well know, because every one of you has experienced a condition yourself or someone you love who's sick, there's a moment where there's something wrong, and there's an endpoint where we're transforming health. And there's a long distance in between. And I think we're finally coming to a place where we can make a difference. And I think conferences like this that will highlight many of those things are going to be very important for that. We need to do this in the communities where we live. I get that now. In my early years, I wanted to break down all these boundaries, these silos. I wanted to just put them away. I think we need to stay in these communities where we see the ones we love, where we're with the people we care about, where we're in affinity groups of any kind, whether it's LGBT groups, whether it's mental health collectives, whether it's actual conditions and diseases. And I think we want to make the boundaries porous. And so our work over the last few years at Genetic Alliance and with lots of great partners has been to do exactly that. At the same time, we started to realize that people have very different perceptions about what they do want to share, how boundaryless they do want to be, how they want their information used. And what you're looking at here is a graph from an IOM report Dr. Alan Weston did that shows the perspectives of people around whether or not they want to consent or to share their information for health information sharing. We see everything from the green end of the spectrum, where everything's open. You know, I'm in the Personal Genome Project and lots of the other open human projects. Everything's free and available. There's some people at that end of the scale, but not everybody. And we see, in fact, a bolus of people in the middle. And then there's a far end where people really do care a lot about privacy. Often we try to do one thing or the other. We react and say nothing should be available, or we react and say everyone has a moral obligation to have everything be available, when most of the time, most of us are in the middle. And we have some solutions in that middle, but we started to look at, we need to build a platform, we call it Platform for Engaging Everyone Responsibly, that allows this dynamic and granular ability to make your values known to the people who want to use your data. And always to think about how do we make this frictionless and easy in the path of people the way so many other parts of our life are. The platform has a core piece. The core piece has many of the same components that lots of things do for registries, for bringing people together, for cohorts, for clinical trials, a data entry facility. You'll see a difference here, though. In our data entry facility, the health data is there, as well as the contact information. We don't want that outside the system. We don't want to say, here's my de-identified data set, because then you lose the ability to work with these people over time. You lose the ability to do longitudinal tracking. You lose the ability to really engage with the condition and the people who have it from the perspective of those individuals. So that data is inside this system and available. You'll see on the other side, on the right-hand side of the rectangle in the middle, the data query facility, again, pretty standard. But what's different here is this privacy layer. A company called Private Access on this coast has given us the ability to put in some privacy directives to tell the actual database what is allowed to be queried so that this permitted information is then given to the research portal. So the idea being that I can set my privacy directives, my sharing directives, my data access directives, and they're dynamic and they're meaningful. So I might give birth to a child who I think I want to keep everything pretty private about this kid. When this child is 2 years old, 3 years old, showing autistic tendencies, I might in fact want that child's data to be available for research, and I can change my mind. You'll see also that we're looking at curated surveys. Those are self-reported data, which we think is very important, as well as genomic data and EHR data. All of those are put in through a customized consumer portal that allows the people to stay in the communities that they live in. So essentially, we believe that while we talk about privacy a lot, we really mean trust. We really mean, who can I actually trust with my data? Who can I give my information to? And we look at things like a community, in this case, the Joubert Syndrome and Related Disorders Foundation. We build this portal right inside their own website so that it looks like them, feels like them, seems like them. It's a trusted entity. We then give this preference portal, which I'll show you in a second. The people give their contact information. They set their privacy directives. Then we give them a screen that allows them to talk about whether they want to answer surveys, whether they want to upload medical records. Eventually, we'll be able to connect with EHR data. That data is all put into a data holder database. Then come the data seekers, people who want to do work on this, data, query the database. They then query the privacy directives to see what is allowed, what is prohibited, and what is ask me. So this maybe is also quite different. Most of these are dichotomous on-off switches, and we say you need this ask me, you need this way to say maybe. And then if a person wants to be recruited for a clinical trial, or a researcher wants them for a clinical trial, again, pinging this contact database with the same kind of process of saying, can I have access to these individuals' contact information to recruit them for a trial? And so this system then respects the individual as the person who makes the decisions about these things, but also gives the researchers the access that they need on the fly and easily, rather than in onerous and very expensive ways. So for the participants, privacy is a surrogate for trust, and about 90% of the people who interact with our platform trust it because they see members from their communities. We've been often told, well, this probably is a pretty difficult thing to do because you're actually asking a fairly complicated thing of individuals, and we actually say, well, if it's in the context of a community and there are guides for them, then it's not so hard. So you're looking at a privacy settings screen. In this case, I'm the guide. This is a generic screen, and you'll see below my picture the dots again from the curve, which say my privacy settings are somewhere in the middle. If this was an actual illustration of mine, they would be way over in the green, but for the sake of this presentation, I've set them somewhere in the middle. And then that allows me to look at the ways that I want to set my directives around certain kinds of information. So you'll see in the columns, in the column on the left-hand side, PanCAN, which is Pancreatic Action Coalition, PanCAN, the organization itself, and then all the researchers who are working with them, then other researchers, and then data analysis platforms. And so this gives me some granularity. I can actually click those open and be much more granular, all the way down to single researchers or single other disease advocacy organizations and other platforms. This allows me to be pretty granular about three things: about who can find and analyze my data. We typically call that de-identified data, and typically we don't ask people if we want to look at that. We're saying, let's even ask people, let's engage people around that, let's have them say yes, no, or maybe. We're looking at export and link, who can export or link to my data, and then who can contact me. And those three things, again, allow me to say allow, deny, and ask me, and we're finding about 85% of people are saying allow, about 10% say ask me, and about 5% are saying deny. So pretty good engagement. Often we're also asked, well, if you give people the right to say yes or no, they're probably going to say no, and you'll be skewing the data, and what about making sure that you're not excluding people, et cetera. Those are really important questions, but I think in a nation where we only have 4% of people participating in clinical trials, if we can move this to 8% or 16%, we will have done a really terrific job. The guides from the communities help the community. You're looking here at some sickle cell guides in a program I'll talk about in a second. They tell a little story so that I can see whether or not I relate to them and I might want to use their settings, or I can customize these settings completely myself. Another set of guides, these individuals, again, will help me to understand, am I like them? Do I understand their story? Do they understand my story? Are they the people that I trust? And again, really trying to put the opportunity to respond to clinical trial opportunities, to cohort development, to registry development in my pocket so that I can answer yes and no. The self-reported surveys are gamified. We find individuals really like to be a lot like everyone else and a lot different than everybody else at the same time, and they can see that instantly in a gamified survey interface like this. We're also looking at matchmaking for genotype and phenotype, so looking at genotypes that are now available through either whole exome screening or whole genome screening, and what the child, often in a lot of cases undiagnosed child, might match with. What we're finding, of course, is that parents will relentlessly search. So while the researchers who are working and the clinicians who are working with these children really want to make these matches, there are a few of them compared to the thousands of parents who want this to happen. And the other thing is they will deeply phenotype their own child. For example, in one real-life case, a father asks another parent, does your child have tears when he or she cries? And the answer is no, and they know they share this phenotypic characteristic that no clinician has ever asked them about, and that's going to be a really key piece to whether or not they do match on some variation in their genome. We all know, and certainly on this side of the country, I don't need to talk much about, and especially after Apple's research kit release and the work that's being done here at Stanford about frictionless data collection, that we can now do this in real time as much as we want to, again, I say as long as we really engage the people who are doing it. And I think people really do want to do this and are able to give this information, and we're able now to really see parts of people's lives that we have not examined before for these purposes. That's a lot of information to give people, so we at Genetic Alliance are really interested also in how do people digest this and what else do they need. So for example, we have this website, genesinlife.org, which gives people information about genetic testing, about family history, about ways to interact with one's own genetic information that hopefully helps people to make decisions. And in another instance, Baby's First Test looks at the newborn screening that's being done all across the nation. All 50 states are cataloged, the tests they offer, the secondary screens they offer, and looks again at what are families learning. And as we move into an age when we'll probably have whole exome or whole genome sequencing for newborns, this is going to be really critical in terms of educating the public. So we need to scale up, we need to make it cheap, and we need to make the little big. So even all of what I've showed you I don't think is big enough. Genetic Alliance has recently received a grant from the Robert Wood Johnson Foundation to scale this up even more, to white label this essentially, to allow individuals to come in and create these portals to look like their own communities easily with the click of a button. Oops, sorry. We've also customized this for several programs and campaigns. This doesn't have to be about disease only. So for example, the FDA is very interested lately, part of PDUFA 5, they're authorizing legislation, and I think on Friday you'll hear a little more about this, around patient preferences. What do people want? Do they want a device to work in this way? Do they want a pill to be taken this many times a day or a month or week or whatever? And what we're doing is helping in a process to get more information to the FDA using this portal. So the sickle cell community used the portal, customized it for 5 or 6 of their communities, and you can see one of them here, the Proudford Foundation, allowing individuals to tell the FDA what they think about this, and at the same time to deliver to FDA a lot of information about the individual's genotype, carrier status, their lived experience of the disease. In another example, Free the Data, this one is much more of a political campaign. We're essentially looking at how do we liberate the tens of thousands, hundreds of thousands of mutations, variations in BRCA1 and 2. Right now, pretty much in Myriad's databases. Can women upload reports? Can we use optical character recognition, take the mutations, put them in ClinVar, and have those be publicly available? Can we also get phenotypic information? And so here we have a campaign where the women themselves, again, using people from their community, people who are BRCA1 or 2 positive, bring that information forward. So PEER, the platform for engaging everyone responsibly, is deployed in a whole host of places. It's deployed in pcornet, which I'll talk about in a second. The Robert Wood Johnson Foundation project has allowed us to bring 30 more communities in, some of which are communities like the American Nurse Midwife Association, women who give birth in hospitals using midwives, campaigns, as I've said, and then advocacy-initiated kinds of activities, and then information for the general public. So now what? I think that's all really terrific. I've spent a lot of years working on this, but I think we even actually need to get beyond just bringing this data together in meaningful ways. I think we need to crowdsource the questions, the methods, and the protocols, essentially to move into the research and blow up what I did in a very kind of plotting way from the days of PXE. And what you're looking at here is a project we just launched on Monday called Mosaic at the University of California, San Francisco. This allows individuals from the community, in this case, again, Joubert, because it was one of our first platforms to launch, to bring their questions forward, to share ideas across caregivers, patients, researchers, clinicians, and to say what is important to our community that we need studied. Not so much what project arises in a lab and can be applied, R01 science can be done, but what's really meaningful to us. There's a debate that happens in an online forum, and you can see that right here. People start to ask questions from the parents' point of view. Caregivers are commenting, genetic counselors, geneticists, researchers. How can we speed diagnosis? What should diagnosis for this condition look like? They go all the way through the process of vetting the protocol, vetting the methods, putting together the project, and actually doing it all in the public space. So everyone watches their whole proposal be built, and then everyone watches them do the research, and all of that is transparent through the process. I'm very excited about this piece. All of this has become part of pcornet, and I think many of you probably have heard of pcornet, the Patient-Centered Outcomes Research Clinical Research Network, funded by PCORI. There are 1,000 researchers, both traditional and lay, so pcori actually counts me as a researcher, which is a kind of first-time official recognition by a big body. 29 funded entities covering all 50 states, very focused on what it means to do patient-centered outcomes research with no one-size-fits-all. The number of people in pcornet now is 72,454,200, which is quite a large number of people in one cohort. These people are in, again, all these 29 entities. We're working together. We have common policies. We have this common set of principles. We have a rubric around patient engagement that knit us together, bring us together, and have us working across cultures, really, that are very difficult to work across. I've worked as the co-chair of the IOM committee that looked at the CTSAs, and I know how hard it is to build networks, particularly with community engagement, and pcori and pcornet are doing that from the ground up. We have distributed data sets now in the tens of millions. That number somewhere north of 50 million, data that is running through a common data model so that we can query that data. So what? That's great. But we pressured ourselves pretty quickly to say, let's look at a study, and in this case, what if these data could prevent 19,000 deaths or heart attacks or thousands of bleeds in the United States? We all know that question. Should that aspirin a day be a baby aspirin or an adult aspirin in simple lay terms? And we're able to query 615,000 records that have met the inclusion criteria with one or more of the enrichment factors that we've needed. So our first study, called Adaptable, an aspirin trial essentially, will look at this question and be really meaningful. We have a couple more weight cohorts, one looking at bariatric surgery, another one looking at antibiotic use in small children and babies and the risk of obesity. These may seem like very simple things, but we're using large numbers of people engaged from the beginning in the writing of these protocols in transparent ways of working together, a really game changer. So some questions are bigger than the biggest data, I would say, and I think the culture eats strategy or data for breakfast. So I think we really need to think about this in a meaningful way. How do we create a culture of openness and sharing? I think the technology is easy. I think lots of great stuff have come out of Silicon Valley, Stanford itself, and the culture things also need to be attended to. Where can we take the friction out of the system? Why do people have to go to 5 visits to get something done? I was with a group yesterday who talked about, if you're an underserved individual and want to get eyeglasses, you need 4 visits because of having to get the exams and then go home and then come back in the bus and, picking up the glasses and they're wrong and all that. Is that not crazy in an age where we could easily have things delivered to us much more quickly? Amazon probably could have those that afternoon on our doorsteps. What oversight is flexible enough to deal with these sorts of engagements and developments? And I know you'll hear about this throughout the rest of the conference as well. We need an oversight system that isn't going to be stuck in 20, 30, 40, 50 years ago when we have to move much more quickly and when we need to be consumer, patient, participant-centric. And how do we animate the American public to get in the game, and not just the early adopters? Because I think, all of us have our Fitbits and we're really, really happy with the apps on our iPhone, et cetera, but we're not the majority. We really need this to be available to everybody the same way other things in our culture are now pretty ubiquitous. Almost all Americans have at least text-based phones. We need to be moving toward things that are in the pathway. And then how do we incentivize ways of working together? I again spend a lot of my time with scientists, with consumers. I have seen that competition is great because it gets people going and moving. I think it also makes us forget the real mission sometimes. And I think when even in the advocacy community, which I've now been in for 20 years and am considered a leader, when we talk about breaking down the boundaries, not so much between these specialized condition-centric organizations, but between the competition for ideas, it's hard. We forget that we're actually not in the business of sustaining a foundation. We're in the business of helping people and alleviating suffering. That is a big jump, because we live in a culture where that kind of competition, where the idea to codify my idea is really important. And I think we're going to want to look in ourselves for the tension, for the stress, for the anxiety we feel anytime someone else is encroaching on us, and that is the place we need to let go and work together. I think we can make huge leaps if we just do this kind of inner work. I now have big kids. They're 27 and 25. My daughter is at Teach for America and just got her master's degree on Monday in special education. My son cultivates both chickens and Drupal. He's a web developer who also has an organic farm. They would tell you they're happy and healthy. They sat us down a long time ago when they were 11 and 9, when we were lamenting with our friends, Francis Collins and his wife, that we had not done enough, that we still don't have a cure, that we still don't have a way to get around this condition. And they said, when you live with a condition and stop fighting it, then you're going to make inroads, then you're going to make progress. As long as you're fighting, you're not going to win. You need to live with it like we do. They live with it every day. They were a real inspiration to me. They have manifestations of the condition that continue to lead to the more morbid and lethal manifestations. But they know that living life to its fullest is the most important thing, and that working as hard as we can together to make things happen is important. So I think we must be bigger than our data, even when we have big data. I think we must risk every day as those who suffer risk every day. And I think we must be boundaryless. Thank you.